Thank you very much, Professor Amjad, for this lovely introduction and this great setup, and my fellow moderators and speakers, lovely talks by Professor May and Professor Tariq and my mentor here, Dr. Samir. So I hope I'll be able to grab your attention in this lecture I organized for our non-nephrologists mainly to share with us our management of nephrology patients, basically. So I'm going to talk about prevention of CKD, a message from the World Kidney Day. So every year, on the first week of March, or first Thursday of March, we celebrate World Kidney Day. That's been going on for the last 17 years, and every year there's a message. The message this year is kidney health for all, basically, which means bridging the gap between all specialties and related to nephrology and the general public. So we need to bridge the knowledge gap to better kidney care, basically. That's what this year's message entails. Because CKD is common and harmful. 1 out of 10 adult people worldwide have it, and if left untreated, it can be deadly. So we need early detection for disease care and management to help prevent morbidity and mortality and improve cost effectiveness and sustainability. Kidney disease-related mortality continues to increase and is projected to be the 15th leading cause of death by 2040. So you can imagine the economic impact as well as the disease burden on the general population. The problem is that there's a persistent and ongoing CKD knowledge gap that exists, one that is demonstrable in all levels of healthcare, okay, between the community, between the healthcare worker, and between the public health policymakers, okay? So the community, the problem is that there's obstacles. The obstacles here include the complex nature of kidney disease information. Patients find it difficult to get the right information and what to do and feel that they're isolated amongst themselves once they develop this disease. There's a low baseline awareness, as you might notice anyway, in the general public, and limited health literacy, limited availability of CKD information, and lack of readiness to learn among some members of the population. The healthcare worker as well finds difficulties, which is another barrier to overcome in order to ensure great awareness in a more focused way for education for physicians as they are in charge of the patient's medical condition, as well as public health policymakers. CKD should be incorporated in the national public health policies. It's a global problem, a global threat, but it's typically low on government health agendas with political commitments on non-communicable disease programs concentrated predominantly on 4 main diseases like cardiovascular disease, cancer, diabetes, and chronic respiratory disease. Okay, so kidney disease should be incorporated. Right from the beginning, which this diagram predicts, like from primary CKD prevention, we should target patients in the general public and the healthcare regarding obesity, hypertension, inherited diseases like polycystic kidneys, solitary kidneys, and diet and everything, and encourage these patients for better glycemic control, so forth. And then in the secondary prevention goals as well, we as nephrologists help in slowing down CKD progression, delaying, deferring dialysis transition, as well as our role in progressing into the tertiary prevention where you tackle CKD, MBD, mineral bone disease, acidosis, fluid overload. So it should be a more organized fashion where we treat our patients, and hence more interaction between local health center, our general physicians in the local health centers, and with us as well. On a more personal basis. So just briefly to catch on CKD, basic definitions is the presence of either kidney damage or a urine albumin to creatinine ratio of greater than 30 milligrams per gram, or decreased kidney function of GFR less than 60 for 3 or more months, irrespective of the cause. Okay, so this is how we stage CKD. Most of us know this. Like it's from CKD stage 1 to 5, as well as the persistent albuminuria categories as well. Why albuminuria? Because we know that a lower estimated GFR, glomerular filtration rate, and higher albuminuria are associated with all-cause and cardiovascular mortality. So a lower GFR and high albuminuria is not good, okay, in high-risk populations, independent of each other and of cardiovascular risk factors. Again, over here, that's how relative risks of major complications of CKD based upon categorical meta-analysis, and that's how, as ACR increases or proteinuria increases, there's a worse relative risk of, in combination with a low GFR, patients show the worst outcome. Again, a lower estimated GFR and higher albuminuria are associated with adverse kidney outcomes, okay? And in acute kidney injury and progressive CKD in both general and high-risk populations, independent of each other and of cardiovascular risk factors. So that's basically what the screening taking place in the local health centers, and that's the basic evidence behind it. So as we see, kidney disease is a global burden of health, and there's 13 million of people developing acute kidney injury per year, okay, apart from CKD. And with a lot of deaths, like 1.7 million die from AKI per year, and most of us don't know this actually, that it's basically worse than many endemic diseases as bad as TB or other diseases. And there's 3 million people on dialysis worldwide, okay? And it's going to be the 5th cause of death by 2040. So chronic kidney disease is a major health problem. For example, in the USA, more than 1 in 7, that's 15% of US adults, or 37 million people, are estimated to have CKD. And we can see here that 6 of the top 10 countries are Asian, like Thailand, Singapore, Japan, Malaysia. And we can see, for example, that there's an inequality in health services in these countries and worse outcomes in other countries. So basically needs more political impact over here to tackle economic issues for CKD management. Causes of chronic kidney disease, mainly, we're talking about diabetes and hypertension and obesity as the most common risk factors in USA and all developed countries. Other risk factors are heart disease, family history, inherited kidney disorders, previous damage to kidneys, and older age plays a part as well. So basic pathophysiology is complex and in large part dependent on the primary cause. We can classify it as hemodynamic injury or non-hemodynamic injury. In hemodynamic injury, what happens? There's decreased with gradual nephron loss, there's decreased perfusion pressure and low solute delivery to the macula densa, release of renin from the juxtaglomerular apparatus. Renin converts angiotensin to angiotensinogen to angiotensin 1, which is converted to angiotensin 2. So what are the effects? You have increased aldosterone production, increase in sympathetic activity, salt and water retention, and stimulates the posterior pituitary to release antidiuretic hormone, which is ADH. Effects of angiotensin 2, there's systemic and glomerular hypertension, proteinuria, and glomerular destruction. What about non-hemodynamic injury? We have activation of the RAS system, T cells and macrophages, upregulation of several growth factors, increase oxygen-free radicals, and more cellular proliferation, glomerular hypertrophy, cellular adhesions, extracellular matrix accumulation, and fibrosis. And as we said, proteinuria, effects of proteinuria are detrimental here in major cause of CKD. What does proteinuria cause? It causes damage to the podocytes, differentiation of mesangial cells into myofibroblasts, abnormal extracellular matrix deposition, and glomerulosclerosis. So this is basically the mechanisms, either hemodynamic or non-hemodynamic, that are implicated in kidney injury causing chronic kidney disease. Albuminuria alone is a strong prognostic factor for CKD progression, as we can see here, where CKD outcomes, this Kaplan-Meier graph shows the cumulative hazard of chronic kidney disease progression as the albuminuria increases into gross proteinuria of over 1 gram. So how to manage CKD progression? Okay, address the underlying cause, manage CKD risk factors, and improve CKD awareness, okay? And this is all the CKD risk factors, basically: age, gender, ethnicity, genetic component, low birth weight, are all unmodifiable. But we have a lot of modifiable risk factors here that we can address. Okay, like drug toxicities, mainly NSAIDs, non-steroidal anti-inflammatories, which are used mainly in people suffering from knee conditions, obesity, and all that. In the general population is a big risk factor nowadays. Hypertension, diabetes, hyperuricemia, like the metabolics in patients with metabolic syndrome, dyslipidemia, autoimmune diseases, recurrent urinary tract infections, oxidative stress, and obesity. Nutrition and diet in patients with chronic kidney disease is key, keeping these patients well maintained on conservative treatment. Okay, so we need to address the nutritional role in these patients to have kidney health for all. So because a higher adherence to healthy plant-based diets and a vegetarian diet was associated with favorable kidney disease outcomes. Okay, so effective screening for CKD is important, and it improves the incidence, okay, and that's by evidence we have in studies of end-stage renal disease and end-stage renal disease-free survival and cost effectiveness. Okay, so screening improves incidence of end-stage renal disease and by 44%, okay, and increase the ESRD free survival, gain in life expectancy after a period of 3 years, improved quality adjusted life expectancy. Its screening is cost effective and leads to improvements in patient outcome and optimal screening strategy. With optimal screening strategy, screening in patients with diabetes and hypertension with renal protective agents as well improves clinical outcomes. So what about this? This is from the Kidney Disease Screening and Awareness Program, an active screening program in high-income country USA, entering the community, meet them where they are. And it showed that it was to serve the community and mobile into the community, meet them where they are, provide free kidney health screening for early detection of CKD risk factors, and to raise the awareness by giving CKD education. And this is how they did it, basically registered by questionnaires, health education, blood pressure, screening, body mass index, urinalysis, blood glucose consultation, things we just do basically on the World Kidney Day. And so the summary here is that CKD is a major public health problem. Okay, we need to address the risk factors, okay, like high blood pressure, diabetes, heart disease, obesity, smoking, And it should be on the public health agenda, okay, mainly because it's the end result of many of our non-communicable diseases like heart disease and endocrine conditions, many diabetes, okay? And it is a risk factor for progression of these diseases to basically end-stage renal disease. CKD progression can be managed by increasing CKD awareness and screening for kidney disease risks. So what do we have to do? Basically, we have to raise awareness about our amazing kidneys, highlight that diabetes and high blood pressure are key risk factors for chronic kidney disease, encourage systematic screening of all patients with diabetes and hypertension for CKD, encourage prevention behaviors and basically harmful lifestyle measures like smoking, poor dietary habits, and so forth. And we have to educate all medical professionals about their key role in detecting and reducing the risk of CKD, particularly in high-risk populations. Okay, but most importantly, we need the personal, basically, interaction between general physicians and us, because with the high influx of patients attending our facilities, which is a tertiary unit for, it really improves the outcome when we discuss them personally with their carers and the community who are the general physicians. It's key role there. And it basically empowers the patients in taking their management and everything further, rather than just sending them back with a note written in the system that this patient is CKD1 or CKD2 or 3, needs this, and the patient goes with a stash of medications and doesn't come and comes back to us for routine follow-up. And we need to stress the important role of, as we said, of local and national health authorities in controlling the CKD epidemic. It's very important for it to be a whole government agenda rather than just something we celebrate on the World Kidney Day. And on World Kidney Day, all governments are encouraged to take action and invest in further kidney screening. And we have to encourage transplantation as a best outcome option for kidney failure, and the act of organ donation as a life-saving initiative. So I gave you one and a half minute, Dr. Samir, so I'm going to finish 1.5 minutes before this. Thank you very much, everybody.